स्क्रीन नजर आ रही है मेरे?
यस आ रही है।
चलो सही है। अब मैं इसको अनशेयर कैसे करूंगा?
आप उसी को अपने शेयर में जाके जैसे किया है उसको वहीं पे उसका क्रॉस का बटन लगा होगा।
स्टॉप शेयर का होगा, स्टॉप
वी आर
शेयर।
लाइव नाउ, ठीक है। एंड लेट मी जस्ट डबल चेक ऑल द थिंग्स। Okay, you can stop sharing the screen and let's see. Okay. Bismillahirrahmanirrahim. My name is Dr. Waqas Nawaz and this is King Edward USMLE Forum session about critical care management in COVID patients. As we promised that we will be doing a session to update all the like doctors who are working as frontline in Pakistan from the basics of the vent management. So the basic purpose of this session is to just create the basic awareness about the vent management. When I'm talking to you today, we have around 10 million patients in the world with COVID. And out of these 10 million, 80% they get better themselves, but there's still 20% admitted to the hospital. People who get admitted to the hospital, at least 40% they get admitted to ICU. So the ICU management is a key role. Okay, I would appreciate all the participants to mute their mic. Okay. Yes. So when you enter in the studio, please mute your mic and then we'll go from there. So to discuss these basics of ventilator management and critical care, we have invited our panelists and they're all critical care and pulmonary medicine people. I'm very thankful to Farooq Abbas, who is critical care and pulmonary medicine fellow in University of Rochester. I'm very thankful to Aftab Ahmed. Aftab Ahmed is the assistant professor, critical care medicine, Mercer School of Medicine, Macon, Georgia. And I'm very thankful to Tala Nawaz, who is critical care and pulmonary medicine fellow, who just graduated, and he belongs to University of South Alabama. So before I move to my panelist, I have some disclaimer. This is a very informal session. As I always say, we are not anchors or we are not media persons, so please expect some technical disruption, and if it happens, that's fine, we will be reconnected. This will be going live on all Facebook pages, on YouTube links, which we have shared. I request all the participants, because many doctors will be joining as the guest in the virtual studio. They can make their video visible, that's fine, but I request them to keep their mics mute. And in the end, we will also get questions from the Facebook. If you're seeing it live, you can type your questions in the comments. And then we have 20-30 minute session at the end, which is question answer session. And we'll go to that session in the end. So please share these links on your walls, tag your all healthcare professionals. We will be doing this session for at least 1 hour, 30 minutes, and we'll try to go over all the basics. So I will move the mic to Farooq Abbas. He is the critical care medicine and pulmonary medicine fellow at University of Rochester. Farooq.
Thank you, Waqas. Assalamu alaikum, everyone. Can you hear me there, Waqas? Can you confirm?
We can.
Thank you. So as Waqas mentioned, the basic purpose of this webinar is to touch the basics about management of respiratory failure with particular focus in COVID pneumonia. So what we're planning to do is we're planning to talk about the basics of how to identify acute respiratory failure with hypoxemia. Then we'll go over the non-invasive.
Okay, Farooq, you are mute. Can you just unmute yourself?
Yeah.
Okay, let's do now. Thank you.
Yeah, so we'll start with the basics about the identification of respiratory failure with hypoxemia. Then we'll talk about the non-invasive management in acute respiratory failure with hypoxemia. And in the end, we'll talk about ARDS with particular focus on the event management. So with that, I'll invite Talha Nawaz, who will talk about the basics about the identification of acute respiratory failure with hypoxemia.
Thank you, Farooq. Assalamu alaikum, everyone. So as Farooq said, so I'll start with basics. So I'm going to share my screen here so that we have this, one PowerPoint presentation which we can look at and talk about things. So can you guys see the PowerPoint?
Yes, we can.
Okay, all right. So I will start with few major, mistakes and misconceptions. They're very basic things, but sometimes we overlook them, and that can be dangerous. First of all, we need to be clear what's the difference between hypoxia and hypoxemia. Hypoxia is basically, low tissue oxygen levels, and that's in shock and multi-organ failure. But hypoxemia, which is basically talked today, is more of about dissolved oxygen concentration in blood and partial suppression of oxygen as we look into ABGs. Next thing is like most common inpatient oxygen saturation levels, which most of the physicians look at are maintaining, is above 92%. But we have to be careful, with that conclusion, since people can have greater than 92% cutaneous saturation, but they can still have mild hypoxemia. And as we go down our presentation, we'll discuss about those situations where we can still be hypoxemic despite your saturation level greater than 92%. And the third thing is dyspnea is not always present in mild hypoxemia. It can be present, but absence of dyspnea does not mean that there's no mild hypoxemia. And mild hypoxemia can present, as we know, most commonly like confusion and people acting funny and those kind of things rather than having difficulty with breathing. So as I said, hypoxia is state of low oxygen in tissue. And then it represents a failure of circulatory system. It could be primarily cardiac, distributic shock, septic shock, various kinds of shocks, and that can cause lactic acid to go up and lactic acidosis. So we treat this not by just giving oxygen. That's a very minor component of their treatment. Major component is to actually treat the etiology of the shock and then increase cardiac output and vascular tone if appropriate. This is just an equation. It shows oxygen delivery to tissues. As you can see, it depends on cardiac output, hemoglobin levels, oxygen saturation, and amount of oxygen dissolved in blood. So this applies more in hypoxia and shock situation. As you can see, PaO2, which is amount of dissolved oxygen in blood, is multiplied by 0.003. So that is not the major factor which we look at while we are treating someone with shock. We actually focus more on cardiac output and hemoglobin. If that's low, we try to fix that. But there are situations where there is shock with extremely low hemoglobin levels, and in that case, even this small amount of dissolved oxygen in blood can become important, and we try to increase that. But that's a minor component. So now hypoxemia. So there is this, partial pressure of oxygen, which we check on ABGs. The cutoff, which is commonly considered, is 60. So if oxygen pressure is less than 60 millimeter of mercury, it is considered hypoxemia. And mild hypoxemia is usually considered, as you can see in that graph, from 55 to 60. And as I mentioned earlier, dyspnea may be mild or absent, but more important features which we should not overlook are confusion, agitation, sinus tachycardia, and tachypnea. Tachypnea is stimulated because patients, if they get hypoxia, they have this hypoxic hyperventilation reflex, which is a central drive, which is not necessarily associated with dyspnea. So dyspnea may be absent, but patient may have this tachypnea. But we need to remember that this, while we are in this mild hypo.
I'm sorry, Tala. I think we got disconnected from the live broadcast. So just wait for 1 minute, okay?
Okay.
Because we have our audience in the Zoom, but we should be talking live. So just a minute. And also keep an eye on that chat box when we are like, it was going very smoothly, but I think something wrong with my laptop. But let's see now again.
Okay. Just let me know when you're ready.
Yeah, sure. Just it's gonna be in 1 minute. Just a minute.
Okay.
Vikas, I think you are live. I can see you on Facebook.
Okay, so that's
Yeah.
fine then. We can go ahead. Okay.
Yeah.
So I thought we got disrupted, but it looks like we are live.
Yeah.
Thank you.
Okay. So as I was talking about mild hypoxemia, so we have to remember this thing that when someone has mild hypoxemia, they are on this steep portion of hemoglobin oxygen dissociation curve, and even a little more worsening of hypoxemia can desaturate them profoundly, like they can fall to 70% on peripheral oxygen, cutaneous saturations. And then severe hypoxemia is usually less than PaO2 of 50 or 55, and they can have extreme dyspnea as opposed to mild hypoxemia, and then they can have lactate accumulation, resting hypoxia, and then eventually, if it gets worse to a point, they can have cardiac arrest as well. So there are various ways of assessing oxygenation and acute hypoxemic respiratory failure. We can, group them into three major categories. There's AA gradient and those discussion, but we'll not go there. We can look at that in these three different, subgroups. So normal oxygenation and room air, we breathe on 21% FiO2, and PaO2 is 75 to 100 milligram of mercury. If we look at that room air levels on sea level, room air at sea level, and if we give someone who has normal oxygenation, 100% oxygen FiO2, then they'll have PaO2 of about 660 millimeter of mercury. Then VQ mismatch. So this is basically one of the mechanisms where we have more perfusion relative to ventilation, and then it can cause low VQ ratio, and it usually corrects pretty well with increased FiO2. And then on that spectrum, there's shunt physiology, which is actually an extreme of low VQ mismatch, where instead of decreased ventilation, there is actually no ventilation. And so this is a severe condition, and this does not usually correct with just giving oxygen, 100% oxygen. We usually treat this condition by increasing mean airway pressure, which is achieved by PEEP, by increasing PEEP. And I think Farooq and Aftab will touch on that later on. Usually in COVID pneumonia, we deal with shunting in severe, COVID ARDS situation. This is a little repetition of the same thing. So we're looking at mechanisms. So mild hypoxemia, when PO2 is 54 to 59, it can present as tachypnea, and which is derived by hypoxic hyperventilation reflex. So if you look at alveolar gas equation, I haven't shared it here, but by decreasing CO2, you can actually increase alveolar oxygen based on that formula or equation. So that's body's reflex to do that. And then when it does that, there's an increased work of breathing. We have to remember that the other supratentorial causes of tachypnea, like pain or anxiety, that does not really cause any diaphragmatic weakness or increased work of breathing, as opposed to mild hypoxemia, which can give you increased work of breathing and diaphragmatic weakness. The next thing is tachycardia. So with hypoxemia, there is pulmonary artery pressure elevation, which can actually decrease stroke volume. So to maintain body's cardiac output, there's reflex tachycardia sometimes, and that's also one of the manifestations of mild hypoxemia. I don't know if you can see that, but this is a picture of a normal PET scan, and you see three organs are lighted up. One is brain and left ventricle, and then renal cortex. So these are the organs which have the highest oxygen extraction normally, and these are the organs which which are affected in mild hypoxemia. So mental status changes, agitation, confusion, and then with hypoxemia, it does cause heart failure with diastolic heart failure exacerbation. It can cause that by various mechanisms. One of that is that it causes subendocardial ischemia, which can cause stiffening of left ventricle, and then the tachycardia, reflex tachycardia, shortens diastole, there's less time for left ventricle to fill, and that also exacerbates heart failure with with preserved ejection fraction. And we have seen that most of the patients with COVID pneumonia, they most of the time have elevated pro-BNP levels, and most of the time that's because of heart failure with preserved ejection fraction rather than myocarditis. Myocarditis is another complication, but that's less common, and usually that reflects with left ventricle ejection fraction reduction, which is not the case here. And then the third thing is acute kidney injury. So these are the early things which can happen with acute mild hypoxemia. Then as we go further down, if PO2 decreases more than 50, then that's a severe hypoxemia, and then there can be extreme dyspnea, which can be very hard to manage. In our experience in ICUs, getting rid of this severe dyspnea is a difficult thing to do, especially COVID patients are intubated, but other patients like pulmonary fibrosis or end-stage pulmonary patients, sometimes that's a very difficult situation to look at, extreme dyspnea. So also they'll have increased lactate production even at rest in severe hypoxemia. And then cardiac arrest from severe hypoxemia is very specific. It usually starts with bradycardia. So heart rate starts dropping from 70, 60, 40, and all of a sudden you lose the pulse and pulseless electrical activity initiates, and then you have to start chest compressions and port patients. So this brings us to evaluation of hypoxemia. So this is just the similar concept. So basically, as I said, VQ mismatch, then shunt physiology is the extreme of the VQ mismatch. And then in VQ mismatch, for example, the lungs, a portion of lung in pneumonia can be filled with some fluid, and then that decreases the area of lung available for ventilation. So that's low VQ. And then sometimes, for example, in asthma, due to bronchospasm, there's not enough air in that lung compartment for, so that's relative reduction of ventilation as compared to perfusion. So we can get that information based on history and examination. In shunt physiology is usually more visible on imaging because they usually have diffuse alveolar damage where there is no ventilation as opposed to less ventilation in low VQ mismatch, and there's actually no air movement at all. So you can see chest X's with diffuse damage, and I'll show you a couple of pictures in next slide. And then there's another term called anatomic shunt, which is not really related to COVID pneumonia, but if there's no abnormality on X-rays or CT scan, then sometimes we consider anatomic shunts, and we look with bubble studies on contrast echocardiogram to look for if there's any intracardiac shunting or extracardiac shunting like AVM or malformation, but it's not really related to COVID pneumonia. So these are some of the pictures. On the first one, you see there's diffuse alveolar filling, so there's diffuse damage, and there's really basically no lung available for ventilation. So that's one of the conditions of shunting. In the next picture, you see left lung collapse. Complete left lung is really collapsed either due to mucus plug or some other reasons. Then it can also show that's the mechanism shunting causing hypoxemia. And then we see two more pictures here. So this is a hospitalized patient. I took this picture from ATS webinar. So they actually, if you see at the first image, you don't really see a whole lot of issues going on in lung parenchyma other than some basal atelectasis. So this is an obese patient who had very difficult oxygenation, even on ventilator with 100% of oxygen and high PEEP. And this is the first X-ray on post-op day 1, and then we see another X-ray on day 14. As you can see, the atelectasis in lower lobe on both sides is resolved, and the gas oxygenation improved a whole lot in this situation. So sometimes it's really hard to tell. Looking at first X-ray, if you miss that there's a significant atelectasis, you would not think that this patient would have profound hypoxemia, but only when you compare it to the improved X-ray, you can really tell how much reduction in lung volume is present there. This brings us to another topic, and that's for pulse oximetry. As I talked a little bit earlier in introduction, pulse oximetry is a useful screening test, but we have to be very careful when we interpret, pulse oximetry. So on oxygen saturation of 91 to 92% on pulse oximetry usually corresponds to PO2 of about 60 uh, at a pH of 7.40. So that's very important to remember, because as pH goes up, then this correlation gets changed, and we'll talk a little bit more about that. So we always have to keep in mind that there's always plus minus 3-point error on pulse oximetry when we have to interpret PO2 based on that, and we have to take into account if patient is alkalotic or acidic at that moment to interpret that. Usually, if pulse oximetry shows oxygen saturation greater than 94%, which is like 95%, that's very reassuring, and you can probably think that PO2 is greater than 60. But make sure there's a good pulse oximetry waveform, and the picture here which you see here is a good pulse oximeter waveform. So if there's a good waveform and the pulse oximetry shows oxygen saturation greater than 94%, there's very high probability that patient does not have mild hypoxemia. And if they're having confusion, AKI, or heart failure exacerbation, that is not related to mild hypoxemia. There may be another cause which we need to look into. As I said earlier, so there are conditions where pulse oximeter would show oxygen saturation greater than 92%, which is the most common cutoff level used in hospitalized patients. But even with greater than 92%, they may still have mild hypoxemia, especially if they are alkalotic. Just carrying on the same discussion, this is a hemoglobin oxygen dissociation curve. This dark green line is at a pH of 7.40. And then you see another curve on left side, which is in a patient with alkalosis. And there's another curve on right side. So basically, acidosis shifts your curve to right side, and alkalosis shifts your curve to left side. I want you to pay attention to this red box here. So as you can tell, this line here represents PO2 of 60. On right side of this one, there's no hypoxemia. On left side of this line, there is hypoxemia. So if you pay attention to this red box, in this case, patient has oxygen saturation greater than 90%, and it's up to like 95%, but they still have PO2 less than 60. So their PO2 ranges from 55 to 60. So they actually, even though their oxygen saturation is greater than 90, with this alkalosis, their PO2 is still less than 60. So they are still having mild hypoxemia. So we have to be careful, with that. And then the other thing to note on this graph is that with alkalosis, this graph becomes more steep. So even a little bit more reduction of PO2 will cause significant decrease in this oxygen saturation. So if you go from PO2 of 55 to like 50, oxygen saturation may drop from 92 to like in 70s or 60%. So this makes it more steep here. So that's something important to consider while interpreting those values. So now, so Farah will talk more about in details on this one, but I just want you to look at this ABG here. So this is a patient who is tachypneic. His pH is 7.46, and his PCO2 is decreased, and PO2 is 60. So even though patient's PO2 is 60, but he is tachypneic, so he is basically hypoxemic at this point, because our goal should be to have PO2 of greater than 60 without hyperventilation if we can, because as I said earlier, hyperventilation, hypoxic hyperventilation response is a body response to actually low oxygen saturations. So they actually hyperventilate. So PCO2 goes down, patient becomes alkalotic, and their PO2 can go up a little bit with that in this case, as you can see. So we should always target for oxygen saturation greater than 94%. That's the most safe thing to do. If you don't have blood gas available, if you don't have ABG available, that's the most safe thing to do, to target oxygen saturation greater than 94%. But if we have ABGs available, then we should target PO2 of greater than 60 millimeter of mercury. Sometimes hypoxemia is severe enough that with low oxygen, which Farooq will talk about, it doesn't really get better. You have to increase the flow and then apply a PEEP and then consider for intubation in those conditions. So this is a big algorithm. I'm not going to go into too many details here, but just basic things. So this patient who is on room air and saturating more than 94% with oxygen pressure of greater than 60, this patient, you can just watch him and he's not hypoxemic. If that's not the case, then you can initiate with nasal cannula. And if they're maintaining oxygen saturation greater than 94 and oxygen pressure greater than 60, you can just wash them. But if that's not the case and patient is requiring more oxygen flow, then we have to consider a trial of non-invasive support versus consider early intubation. And Farah will talk more about that. But every institute has different, protocols and algorithms. If you have one in your hospital, stick to that. But from this one, actually you can see patients where we can consider trial of non-invasive support would be ideal, or good candidates would be who have some underlying lung disease like COPD or asthma, which gets some help with non-invasive ventilation, or they have cardiogenic pulmonary edema, or if they have some other risk factors for cardiac edema like AKI. In those patients, you can give a trial of non-invasive support. But if patient does not have any of those conditions and they are having rapidly worsening oxygenation, you can bypass non-invasive ventilation and go straight to invasive ventilation. And if someone is on non-invasive and then they're not doing too well, later on you can consider intubating them. So here I'll actually stop here and then hand over discussion to Parak, who can actually talk about non-invasive ventilation as well as other modes of providing oxygen to patients.
Okay, thanks so much, Tala. That was a very comprehensive presentation about the detection of acute respiratory failure. So for people who joined in late, if I have to summarize what Talha said, basically, PO2 of 60 is the magic number, but most of the patients do not get an ABG. So just make sure if patient does not have an ABG, their saturation target should be greater than 94%, because less than 94% on the pulse oximetry does not correlate as well with a PO2 of more than 60 on the blood gas. So, Tara also spoke about the importance of identification of mild hypoxic respiratory failure, and mild hypoxemic respiratory failure may present with more of like tachycardia, agitation, and tachypnea due to hypoperfusion of heart, lungs, and brain. And the dyspnea may actually come in later. So that was an important point. The other important point Talha focused on was that in alkalosis, the binding of oxygen to hemoglobin can increase, and the oxyhemoglobin curve can shift to the left. So it is important to recognize that, because that will lead to more, it will not help the hypoxemic respiratory failure. Before I
think
start,
we are still in the share mode. If you, Tala, you can stop sharing your screen and then we go to the speaker mode. I'm trying to, but I think I can't do remotely.
Okay.
Okay, let's go back to the speaker mode. Okay.
So before I start my talk, I would refer all of you to one important resource for critical care training, and it is from American Thoracic Society. It is called ATS COVID-19 Critical Care Training Forum. ATS COVID-19 Critical Care Training Forum. If you type it in Google, it will directly take you to their website. What they are doing, basically, they are doing these webinars on the basics of critical care training, and they are focused on people who are not critical care training, and they have done at least 9 or 10 sessions so far. Like, for example, one of their sessions was on sedation. The session which is oncoming is on hypercoagulability in ICU patients. So if you go there, all of their recordings are online and they're free. So it's really helpful. So I'll suggest you going to that webinar.
Farooq, before you start, I would request all the participants that they can, if they want, they can turn on their cameras also. This way we have like a better view, a grid view. And the second thing, they can post their questions in the comments. People who are not in the studio, right now we have 25 people in the studio. The people who are not in the studio, but they are listening us live on Facebook, YouTube, they can write their questions. If they don't want, first of all, they are more than welcome to come in the studio in a mute mode with the video on, with their name and the city they can put, or medical college they can put. But if they don't want to come, they can still listen us live and they can put their questions. Thank you very much, Farooq. Back to you.
So I see a question from one of the participants, Talha, that what if the respiratory alkalosis does not resolve, but the patient still, the respiratory alkalosis continue to get worse despite non-invasive positive pressure ventilation, what's next? So I'll touch that at the end of my talk, but that probably is a failure of non-invasive positive pressure ventilation, and that patient may end up needing ventilation, mechanical ventilation, but we'll talk about it. So my topic, I'm gonna share my screen, and then we're gonna start. Just let me share the screen. Okay.
Yes, we can see.
Okay, great. All right, so I'll be talking mainly about non-invasive management of acute respiratory failure, mainly with hypoxemia. So types of respiratory failure, as Talha mentioned, that in COVID-19, most commonly is from physiological shunt. And what physiological shunt is, basically part of the lung is consolidated, and that part of the lung is perfused, but there is no oxygenation or ventilation. So this is just like the blood is going from the right heart to the left heart, bypassing the lung. It's going through the lung, but the lung is not doing its job. So that is the most common way people get hypoxemia in COVID-19. The other ways they can get hypoxemia is from hypoxic vasoconstriction, or microangiopathy, or venous clots that can happen in some of the COVID patients. Hypoxemia can also happen from sepsis, which is basically increased tissue utilization of oxygen. Hypercarbia is not common in COVID-19 patients, but COVID-19 patients who have obstructive lung disease, especially COPD, or they have obesity hyperventilation syndrome, they will be hypercarbic. Patients who have been basically working pretty hard for hours and hours, they can become altered because their respiratory drive will go down. Ultimately, they'll get tired, and they will go into hypercarbia. Patients who are on sedatives like oxycodone, patients who get IV sedatives or narcotics, they can also go into respiratory hypercarbic respiratory failure because of decreased respiratory drive. A patient can have a mix of hypoxemia and hypercarbia. So what are the non-invasive systems of managing acute respiratory failure? So I'll touch on the basics of these systems, which include nasal cannula, venti-mask, non-rebreather, high-flow nasal cannula, CPAP, and BiPAP. So we'll first talk about the basics, what they are, what's their capacity, then we'll talk about their utilization in respiratory failure. So the choice between all these modes of support will depend on patient clinical status, their degree of hypoxemia, their respiratory distress or work of breathing, and presence or absence of hypercarbia. So regular nasal cannula, a standard nasal cannula, just remember it's a low flow nasal cannula. It usually cannot handle more than 6 liters per minute. So even if you dial the oxygen more than 6 liters on the wall, the size of the tubing is not big enough to handle usually more than 6 liters. So just remember, if someone has reached 6 liters per minute with a regular nasal cannula, even if you have dialed it to 10 liters or 15 liters, they're probably not getting more than 6 liters. There are intermediate nasal cannula where the tubing is a little bit bigger. Their tubing is similar tubing as like venti-mask or a non-rebreather. So those intermediate nasal cannula can handle up to 15 liter, 10 to 15 liter. So I'm not sure if every hospital in Pakistan do carry those bigger tubing, but it is worth asking the respiratory therapist when the patient is requiring more than 6 liter to see if they can be transitioned to intermediate nasal cannula, which can handle 10 to 15 liter. Venti-mask, they fit loosely around the mouth. Some patients prefer mask more than nasal cannula, so it usually is a better option for those patients. Their flow rate is usually 6 to 10 liter. Their oxygen concentration is between 35 to 50%. Non-rebreather is actually, it can very reliably supply highest concentration of oxygen up to 90-95%, which is big. You know, a ventilator provides like 100%. So this non-rebreather can provide 95% FiO2, and their flow can be 10 to 15 liter per minute. With the non-rebreather, just make sure the mask is like not loosely fitting. Try to fit the mask well on the patient so that they can get maximum amount of oxygen. So if someone is on non-rebreather and they're still hypoxemic, that is bad. You know, that means that patient will probably need something, you know, non-invasive or even mechanical ventilation. Next is high flow nasal cannula, and I'm not really sure. I'm sure that most of the government hospitals probably don't carry the high flow nasal cannula in Pakistan, and correct me if I am wrong. But some of the private hospitals can carry it. This is actually a great non-invasive mode of oxygenation, mainly in respiratory failure patients. Most of these patients can tolerate it pretty well, more better than the mask like CPAP or BiPAP. It can provide 100% FiO2. It can provide up to 60 to 70 liter per minute flow. And with a higher flow, it also provides some positive pressure, about 3 to 5 centimeter of water. The high flow nasal cannula is basically mainly for patients with hypoxemic respiratory failure. And we also use it in patients after post-extubation, but we're not talking about that. But the high flow nasal cannula is mainly for hypoxemic respiratory failure. It does not provide ventilation, but it can help people with the hypoxemia and respiratory distress. CPAP, I'm sure most of the people are aware about that. It provides continuous pressure. So during inspiration and expiration, it provides continuous pressure. This is similar to like PEEP on vent. And CPAP is mostly used in chronic settings like in obstructive sleep apnea, obesity hyperventilation, some of the patients with obesity hyperventilation syndrome. But in acute settings, CPAP can help with pulmonary edema, atelectasis, and workup breathing. So the basic mechanism is that it provides the continuous pressure. It tries to keep the lungs open, right? It tries to keep the lungs open. It prevents atelectasis, and it mainly helps with oxygenation. Again, because it's a continuous pressure, it does not really help a lot with improving tidal volume, but it is more helpful with patients who have like pulmonary edema, they have atelectasis, and it can help with some workup breathing. You know, it can help with tachypnea by improving oxygenation. So usually, you know, if someone is not on CPAP at home, you can start at a pressure of 5. Obese people who have big, you know, they have thick chest wall, heavy chest wall, a big belly which is pressing on the diaphragm, they usually need a higher pressure. So in those people, I probably would start with like 8 or 10. If someone is on CPAP at home, you want to start with at least their home settings, whatever they are, and at home, if they're at a fixed pressure of let's say 12, you want to start with like 12 or 14 at least. If they are on an auto titration CPAP, you can start at a higher end of their auto titration CPAP pressure. And then is the bilevel positive airway pressure, which is commonly known as BiPAP. So the difference between CPAP and BiPAP is that the BiPAP provides inspiratory pressure and a separate expiratory pressure. So the difference between the inspiratory pressure and expiratory pressure determines the tidal volume. And this is mainly used for patients with hypercarbic respiratory failure, because you want to improve their ventilation by improving mainly their tidal volume. And just remember that we would not use BiPAP for patients who are obtunded or unable to breathe. So the patient needs to be breathing spontaneously because this is not a ventilator. Although BiPAP has a backup rate, but the patient has to, in most of the, for the most part, initiate breath. If the patient is not able to initiate breath, BiPAP probably would not be a great choice. Also, BiPAP and CPAP both, you don't want to use it in patients who are vomiting or have non-resolved small bowel obstruction or large bowel obstruction, because what they can do, they can have emesis into their mask, and that can all be pushed into their lungs, and they can go into severe aspiration related respiratory failure on top of respiratory failure, whatever they were having. So just remember that. And I'll go into the, I'll touch more about the EPAP and IPAP in next couple of slides. So what you want to do is like when you put the people on the patients on BiPAP, the common mistake I see, they get put on BiPAP or whatever pressure, and then you basically don't evaluate how well it is working. So the reason we put people on BiPAP is that you want to improve their mechanical, you want to improve their ventilation, mainly the tidal volume. So on BiPAP machine, there are two views. One view will tell you what the settings you set, the basic settings on BiPAP. The other will be the patient data. And you really want to look at the patient data and want to make sure the patient is drawing good tidal volumes, like 500, 600. If someone is drawing a tidal volume of 200, normal size person, 250 consistently, that means BiPAP is probably not working. You also want to make sure the patient has a tight seal of mask on his face that can be checked with, just a physical check. You can place your hand around the mask and you will know if there is a leak or not, because you will feel it. And then you can adjust the mask as tight as possible so there is no leak. Make sure there's a starting delta. If someone gets started on a BiPAP of 10/5 and they have severe hypercarbic respiratory failure, it probably won't work unless you can see the tidal volume. If they're drawing tidal volume of 500 or 10/5, great. Otherwise, you want to start like at 12/5, 14/5, something like that. Some people, just remember, some people don't tolerate a higher respiratory pressure. It's a lot of pressure. I'm not sure if any of you have tried BiPAP, but it is not the most comfortable thing in the world. But you want to give them a delta. Delta means the difference between IPAP and EPAP. So you want to give them delta of like 7 to 10 in order for them to draw good tidal volumes, and then just see how they do. Patients who have obstructive lung disease, mainly COPD, not asthma. COPD people usually require a very high delta. Usually, you want to start them at least on like 18/5 or 6, something like that. Give them a delta of 10 to 12 and give them a higher inspiratory pressure. And sometimes they even require 22, 24 or like 8, something like that. Usually an inspiratory pressure on BiPAP more than 22, 24 does not provide any additional benefit with ventilation. But COPD people, just remember, they usually require a very high delta. So how do we choose between these modes? Before I go into that, I'm going to show you this one small slide of BiPAP. You can see, and there are different devices from different companies. This is from Respironics. You can see this. If you can see my arrows on the left side, this is what you have. This is the mode of BiPAP. This is the data that can be changed by you. And this will be on the right side, the patient data, what the patient is doing. So what you see here, that the IPAP is 12, EPAP is, let's say, 4. This patient has a delta of 8. And these are the two main things that you want to set. You can also set FiO2 on most of the BiPAP. You can set the backup rate of 10. But again, as I said, this is like if someone is not spontaneous breathing, then they probably should not be on BiPAP. So backup rate usually does not matter in most of the patients. And then here on the right side is the most important thing. You can see that the rate patient is breathing at a rate of 31. So you want to follow that patient. Then when you're starting the patient, their respiratory rate is 30, 31. And if BiPAP is working, their workup breathing will decrease. Their respiratory rate in, let's say, half an hour, 1 hour will come down to like 25, 24. It's working. That means working. But if in half an hour, 1 hour later, their respiratory rate is like 40, 45, it's not working. That patient probably needs mechanical ventilation. The other thing you want to look at is the tidal volume. That's the most important thing I have been talking about. This is like little blurred here, but this basically says the tidal volume is 203 ml, which is not great. So you want to look at the tidal volume. The tidal volume should be like anywhere like 400, 500 at least for hypercarbic respiratory failure. I'm not talking about hypoxemic here. BiPAP, again, just remember, is we're talking about hypercarbic respiratory failure. So you want to look at the tidal volume, make sure patient is drawing good tidal volume. So those are the two most important things on the patient data that you'll be looking at. You can also look at the air leak on the machine. And here, like it says 47 liter per minute, which is a lot of air leak. Usually you should be less than like 10 liter per minute, ideally less than 5 liter per minute. So this is like the basics of like what these devices are and what they do, but how do we choose between different systems? So usually patients who have mild acute respiratory failure with hypoxemia, you will start with nasal cannula or venti mask. Some patients prefer a mask than a cannula, but most of the people do fine on nasal cannula. And then, if they have reached like 6 liter, you want to increase that. You want to go to intermediate nasal cannula, or you want to go to initially venti mask, or you want to go to non-rebreather in those patients to provide higher FiO2. Because the in terms of the flow, venti mask will also provide the same flow, like 15 up to 15 liter as non-rebreather. But the non-rebreather will provide 95% FiO2 as opposed to venti mask, which provides, let's say, 50% at maximum FiO2. But just remember, if someone is with acute hypoxemic respiratory failure, is in respiratory distress, like if their respiratory rate is like more than 25 or more than 30, then that patient probably needs something more than those, non-rebreather. Non-rebreather may still work, but definitely more than nasal cannula or venti mask. Those patients will probably need like high flow nasal cannula or CPAP with a higher like 100% FiO2. And then once you start them on that, you want to follow them clinically, that how they are doing, like their workup breathing, if they are using accessory muscles, their tachypnea, their tachycardia, if they were agitated, their mentation, if that is improving or not. And then you want to follow them with maybe in some cases a blood gas, like if our saturation more than 94% or even 92%, that is probably reliable. But if they're clinically doing great, that you probably even don't need a blood gas. But if they're not doing well, then you may consider an ABG to check their PO2 if their oxygen saturation is not reliable. Patients who have hypercarbia, you will start them with BiPAP. The patient who have acute hypercarbic respiratory failure or acute and chronic hypercarbic respiratory failure with who are spontaneously breathing. You will start them on BiPAP, then you will follow them clinically, that you will follow their respiratory rate, workup breathing, their tachycardia, their mentation, and then as importantly, on the BiPAP, like the good tidal volumes, their respiratory rate on the BiPAP is getting better, their air leak is not there, and then you want to follow them with a blood gas. Usually a VBG, these patients who are started on BiPAP is mainly for hypercarbic respiratory failure. So the VBG is usually reliable. There's a difference of about 5 to 10 millimeter mercury of PCO2 between an ABG or VBG. The VBG is usually higher, and it's usually VBG is reliable for tracing the PCO2. But if you want to trace the PO2, in case the oxygen saturation waveform is not great on pulse oximetry, then you will need an ABG. But the other problem comes in patients with COVID-19. So patients with COVID-19, and my slides, actually, I'm going to stop my slides because they end here. But I want to talk about in COVID-19, how do these systems work differently? So So in COVID-19, just remember
I'm
there was.
sorry, I have to interrupt here. So I think Aftab has to leave in 10 minutes.
Okay.
And then we can just involve his participation and then we get back to you.
Okay, that's
We
fine.
also should not run short of time.
Yeah, sure.
So,
All right, Aftab, here you go.
Aftab is busy. Actually, he's at work, but and I will get back to you on this. Okay.
Yeah, no worries. And I can whatever is left by Aftab, I will.
Yeah, and then because we have 20 a lot of people in
No
our
worries.
studio.
Yeah.
And what we will do, we'll try to involve all of them and they can share their experiences because they are practically working in the front line. They can share their experiences, their questions, concerns, and problems which they faced while managing the respiratory failure patients in Pakistani ICUs. And our experts can try to answer the questions. This will be more interactive. So I'm moving to Aftab Ahmed. Aftab Ahmed is Assistant Professor, Critical Care Medicine, Mercer School of Medicine, Macon, Georgia. And I'm thankful to him that he's at work right now, but he spared some time for us. Aftab.
Assalamu alaikum. Thanks, Vikas. Vikas, can you bring my slides?
Okay, let me share slides. Okay, so, let me know when you can see the slides.
Yeah, definitely. So I think I'll start regardless. I'm just going to quickly touch the acute respiratory distress syndrome and very basic mode of mechanical ventilation. There seems like a lot of fear in Pakistan about ventilator. We just want to share that there's nothing scary about a ventilator. You can easily manage it. These will be the basics, and then you can definitely build on them. We can talk more about ventilator.
Okay, you can see the slides?
Yes. So first of all, it's very important to identify acute respiratory distress syndrome, because if you're going to use ventilator for ARDS, you need to be sure that this is ARDS, okay? There could be other things that you have to manage differently. So there's a standardized definition for that. It's called Berlin criteria. It says that the respiratory symptom onset should be within 1 week of a clinical insult, like let's say aspiration, you have pancreatitis, any reason that gives you a respiratory insult, okay? You need to have bilateral opacities on the chest X-ray. And that should not be an effusion. That should not be atelectasis or collapse, because those are managed differently. Then you have to have a PO2 FiO2 criteria. What is PO2? Basically, you draw blood gas and you see what's the partial pressure of oxygen there. FiO2 is what oxygen you're giving. Let's say the partial pressure is 100 and FiO2 is 100%. That would give you a PO2 FiO2 100 of 100. So you have mild, moderate, and severe ARDS. If PO2 FiO2 is less than 300, that's mild. If it's less than 200, but above 100, that's moderate. If you have less than 100, that's severe. And 120 or 150 is an important number to remember. I'll get back to that later. And it should be a non-cardiogenic opacities bilaterally. You can have pulmonary edema appearing like bilateral opacities, but that is managed with diuretics and like a cardiogenic edema. So you need to be sure that it's non-cardiogenic. And one of the things that you can do is get an echo, a bedside echo, make sure the ejection fraction is okay and all of that. Once you have determined it's ARDS, and then the patient is on a ventilator, there are multiple modes of ventilator. It's a very detailed discussion. We'll go over one basic mode. If you want to, let's say you are the person there, you don't have immediate help available, but you have a person on a ventilator, you can, this perhaps is the easiest mode to understand, the volume control. Now you will see in that volume control, there are 4 important things. F, you see there, that's the rate in green arrow. Vikas, keep the previous screen.
Okay, let me know when you want to move. Okay.
The tidal volume. Then you have where it says O2, you have the oxygenation, the FiO2, and then you have the PEEP, the positive end expiratory pressure. So basically, these are the 4 very important numbers to remember. There's a lot of other numbers on the screen too that you see. A lot of them come by default when you put the ventilator on setting. But I'll get to the next slide why these 4 things are important. Vikas, can you move to the next slide?
Just a minute. I think there is something wrong with.
I can still continue without.
You continue. I'm trying to share. Okay.
Basically, one thing, the definitions that you need to understand clearly are the rate. What is the rate on the ventilator? That's the rate that ventilator is going to guarantee the patient. Let's say you set a rate of 20, the ventilator will give 20 breaths. Tidal volume is the volume that the ventilator will give on this volume control. You set 500, 400, that's the volume that ventilator is going to give in 1 breath. What is the FiO2? That's the percentage of oxygen in that breath. So you can keep it 21%, 100%, when can go up to 100%, like pure oxygen. What's a PEEP? The positive end expiratory pressure. That's a sustained pressure that you have, the ventilator will keep to keep the lungs open, okay? And that you can also dial in on this volume control mode. And we'll discuss a little bit more about this in the next slide. The PEEP is important for oxygenation. And then ventilator gives a positive pressure breath. So what is peak pressure? Peak pressure is the full pressure that ventilator has delivered with each breath. So it will involve all the pressure that is transmitted through the endotracheal tube all the way down to the lungs. So if your airway resistance is high, if you have a clot in the ET tube, or if you have clogged ET tube, that the peak pressure will go high. That's why plateau pressure is more important, because that's the pressure that is reaching the lungs. So how you calculate that plateau pressure, a lot of ventilators will auto-calculate, but to accurately calculate, you do the end inspiratory hold for a second, and it will give you what pressure in a static environment the lung is feeling, because the more the pressure, the more the chances of lung injury. And the number you need to remember on plateau pressure is try to keep it below 30. Driving pressure is similar concept. Basically, it's plateau pressure minus PEEP, and you want to keep that number below 15. Intrinsic PEEP is important to remember. If somebody you're not giving enough time to exhale the breaths out, the air will keep trapping in the lungs, and they will develop the intrinsic PEEP. You can do an expiratory hold maneuver to see if that's the problem. Because if you develop a lot of intrinsic PEEP, that is going to affect your all the ventilator mechanics. And it can also cause hemodynamic compromise. And the way to get rid of intrinsic PEEP is just to disconnect the circuit for some time, let all the air blow out, and then reconnect it. Okay, I think the next slide is where we will have more detailed discussion on managing this volume control. So basically, the easiest way to remember is, okay, it's way more complex than that. The goal is to simplify it as much as possible. How do you oxygenate?
This is the slide?
Yes.
Okay.
So how do you oxygenate the patient on a ventilator? Pretty much everything comes into play, but the main things are PEEP and FiO2. You can up-titrate FiO2 to give more oxygen. You can up-titrate PEEP to give more positive end expiratory pressure. You open up more lungs, and they can participate in gas exchange. But you cannot overdo it. If you over-distend the lung, then there will be shunting. The next thing is ventilation, means how to get rid of carbon dioxide. You have your tidal volume. You increase the tidal volume, you'll have more breath volumes. You can blow it out, you can increase the rate. Now, let me tell you how you interplay all of this. What are your goals on ARDS? You don't want to injure the lung that is already injured, okay? So you don't want to give a lot of unnecessary pressure. You want to optimize your pressure. Your key thing is oxygenation. So generally, remember one thing: whenever you intubate somebody, you have to know their minute ventilation. What was it? What's their approximate minute ventilation before you intubated them? Because then, when you sedate them, you cannot suddenly decrease their minute ventilation from 20 to 10. You initially match it, and then you slowly start taking control over the vent. So you can, by reflex, go up to FiO2 of 100%. That's fine when you initially intubate, and then you start optimizing your PEEP. So always remember that without PEEP, ventilator can be actually dangerous, because you cannot have a lot of atelectasis and then try to give positive pressure vent. So you need a good PEEP. What you can remember is you can start with 6, 8, 10, and then slowly start going up on it, okay? And how, if you have to oversimplify it, how will you know you have reached your optimal PEEP? If you're keeping your plateau pressure less than 30, you have room to go up. So set your tidal volume at 6 cc per kg. Again, once you have to control over the ventilator, okay? Like you initially match their minute ventilation, but then 6 cc per kg ideal body weight. Calculate their ideal body weight with their gender, height, and weight, and then multiply that with 6. That would be your tidal volume. And then that volume vent is gonna need to generate some pressures, okay? So that's where the plateau pressure kicks in. Keep titrating your PEEP up. If your plateau pressure is staying less than 30, most likely you are on the optimal part of the pressure volume curve, and your PEEP is helping recruit more and more lungs. And then let's say your PEEP is still, you don't think it's optimized. There's a big patient, you need to give more PEEP. You can drop the tidal volume a little bit. That will drop the plateau pressure, and then you can up titrate your PEEP. And then you can follow the high PEEP, low FiO2 oxygen table. You can easily Google it and titrate your PEEP and FiO2 accordingly. Ventilation, we have discussed, that's the key part is that you need to keep carbon dioxide in control, but you don't have to strictly control it. There's a thing called permissive hypercapnia. You can sacrifice a little bit of tidal volume. You can keep your CO2 close to 60, pH above 7.2, that's fine. The next thing is sedation and paralysis. So sedation is very important. Ventilator can be dangerous without appropriate sedation. You don't want the patient and ventilator to be dissynchronous with each other. You need synchrony. So you sedate them again, depending upon what medicine you have available. You can follow the Richmond agitation scoring system. Keep it close to like -1. If the ARDS is progressing, that's when you have to completely sedate them. Remember, that's very helpful. Once the ARDS approaches severe category, the PO2 effort is less than 150 or 120, just deeply sedate, almost medically induced coma. And then when it's below 120, you should paralyze them too. And again, you need to make sure that your hospital has adequate monitoring measures. You cannot have somebody paralyzed without adequate sedation. So they should be adequately sedated. You need to have monitoring. Some hospitals have BIS monitor or something. And then paralysis, you can do the train of 4, the twitching method, whatever your local hospital has, make sure that they're adequately paralyzed. Sedation and paralysis is going to help you take over the control of your ventilator, and then it will also decrease the dyssynchrony, and you can optimize your pressures and settings. Next thing is proning. Try to establish a proning protocol in your hospitals. It's not that difficult. From what I have spoken to my colleagues in Pakistan, proning is not being done in ventilated patients. You need to have a good team. Somebody needs to, like, there are YouTube videos and everything. You basically need 4 or 5 people. One person is going to watch the lines. Somebody's going to make sure the ET tube doesn't get displaced, and you need few people to flip them over on their stomach. You keep them like this for like 16 hours, 8 hours flat. And then if you see their PO2 FiO2 is still was responsive to proning, but when you put them supine, they're again starting to desaturate. You again do it for 16 hours, and you can do multiple cycles. The next
I'm sorry, I'm interrupting you. I would like you to here just explain in briefly how proning helps with the sick lungs in COVID, because this is something not being done in Pakistan, and we really have to give emphasis on it. So if you can just let our people know how actually it really helps.
So basically, when you're proning, you're putting them on their stomach, right? You have more dependent, in ARDS, you have more dependent collection on the posterior side. So you're basically now even out displacing all the inflammatory fluid that was in the lungs, okay? So you have created a more lung that is going to participate. You have moved the heart away from the lungs too, okay? And basically, if I have to put it in one word, you have decreased a lot of shunting that is happening. You have more lungs available to interact with the oxygen, and then you don't need those aggressive settings on the ventilator. And then again, the thing is that on a ventilator, you cannot keep somebody on ventilator for a very long time on high pressure and expect the lungs to heal. You have to do every maneuver possible to make sure you're giving minimal settings on the ventilator and allowing time for the lungs to heal. So that's where proning comes in. It helps you keep the lower ventilator settings, gives more time to the lungs to heal. So please make sure if you can work on proning protocols in your hospitals, that is going to help a lot. I'm telling you, this is one of the things that decreases mortality based on studies. So this is important as you guys move forward in the COVID-19 pandemic. More and more patients will need ventilator. Have a proning protocol in your hospital. It's a simple, no cost almost, and one of the most effective measures to help. Next thing is steroids. Again, you can use the DEXA ARDS steroid protocol. You can use the Meduri hydrocortisone solomedrol protocol, whichever you prefer. DEXA is the latest one. A lot of intensivists are using that, and that is, remember, different from the DEXA COVID, the study that came from UK. That is pretty much used. They use it on pretty much all the patients. The steroid protocol for ARDS is very specific, so make sure you use this if your institution has a protocol when you're using them for ARDS. The monitoring, I'll tell you some simple things about the monitoring. Remember this thing: whenever you make a change on the ventilator, see how that change affected their plateau pressure, their peak pressure. Okay, remember these two things. If you made a change, let's say you increase the tidal volume and the plateau pressure shot up from 28 to 36, there's something that you need to see. The lungs are maybe not that compliant to afford that tidal volume. The other thing is rule of thumb. Again, this is a little bit oversimplification, but remember, whenever you have made a ventilator change, it's safe to get a blood gas in 1 hour, and just to see the effects of those changes, and that will help you guide moving forward. Let's say you have seen improvement, or deterioration or steady state that will help you guide how to keep on making further ventilator changes. And I'll have to leave here, but I'll tell you one thing, that we are all, whenever we are not on service, whenever we have off time, we are available to answer any questions. I think Vikas is going to work on that to see if we can do like ventilator consults, help you guys answer the ventilator questions. I think one thing in US training for critical care is there is heavy emphasis on, you pretty much spend years learning ventilator, so you become more and more comfortable. We will be, from whatever we know, we'll be available to help you guys. The goal is that hopefully take that fear of ventilator. We have been hearing that ventilator, anybody going on ventilator is not coming back. It's not the fault of ventilator. Once we learn how to manage it correctly, it's gonna be helpful. And on that note, Vikas, I will leave, and I'll have Vikas and Talha and Farooq and all of you take it from here on.
Thank you very much, Aftab, for sparing some time. And I know you were working, but thank you very much. And yes, Farooq and me, we have started working on arranging the EICU program, and we will work and we'll make sure that our fellows and attending who are working in America, they may be available to the people, our colleagues working in Pakistan, sharing their experience and expert advice. And this way we can work together. I will move back to Farooq, and then we should be involving in like next 15 minutes, all our participants, we will be involving them, and they should be ready with their questions, concerns and comments very briefly, and then so that it will be more interactive.
Yeah. Okay, because we have already started ARDS, so I'm gonna touch ARDS first, because Aftab was working in the ICU, so he had to rush through some of his slides, but this is the vent part, is one of the most important part that we want to cover today. So can you bring the slide with the vent picture?
Slides?
Some of the slides. So I want to just go through that little bit in detail.
This one?
Yes, thank you. So just remember, in ARDS, the thing that improves survival and reduces mortality, the most important thing is low tidal volume ventilation. So you have to understand this slide in order to understand the low tidal volume ventilation. You see on this slide on the left lower corner, there is F, which is respiratory rate. There's VT, which is tidal volume. And then on the right side, right lower side, you see PEEP, which is set as 5, and above PEEP you see O2, which is FiO2. So these are the four most important things, are parameters that you will be setting on the ventilator. Okay, F, VT, tidal volume, on the right side FiO2, and the right lower side is PEEP. And what you want to do on the V tidal volume, that is the low, this is how you will set the low tidal volume ventilation. So you will try to calculate the ideal body weight of the patient based on gender and height. Those are the two things you will need. And then you will set a low tidal volume, which you will start with 6 cc per kg. And in some patients, you have to actually gradually, severe ARDS, gradually decrease it to 4 as well. But you will start at least 6, not more than 6. And for that, you will need a higher respiratory rate, because you're decreasing the tidal volume. In order to achieve a minute ventilation, you'll have to increase the respiratory rate, usually around like 22, 24. But just remember, when you have set these settings, just look at the top line on this slide. So you have set the respiratory rate at 24, but this patient is breathing at a rate of 24. Okay, so that means the patient is breathing about at the same rate the ventilator is set. That means this patient is either heavily sedated or even paralyzed. Because most of the patients, just consider on yourself, if you are drawing in low tidal volume, you will feel uncomfortable. So the patient don't feel comfortable on low tidal volume, and then they try to take extra tidal volume, and then they try to breathe faster. And the ventilator has an auto flow. So the ventilator would, in most of the cases, the ventilator will allow them to take extra tidal volume and will allow them to breathe higher than the set respiratory rate. And if they're taking an extra tidal volume, then you're not, basically there's no tidal volume ventilation, because you have set it on the ventilator, but they're taking, like if it is set at 500, they're taking 600, 700, then it is not working. So you want to look at the right corner, look at the right upper corner where it says VTE, expiratory tidal volume. It shows 522, which is great. You know, you have set it at 500, so it's about there. So these patients, just remember when they are drawing an extra very higher tidal volume, let's say if they're drawing 600, that means that patient first you will need to increase sedation. And once they're fully sedated, if they're still drawing higher tidal volumes, then you probably might even need paralysis for those patients in order to achieve the low tidal volume ventilation. Okay, so that's very important. And the second thing is with low tidal volume ventilation, what you will get permissive hypercarbia, right? You're giving them low tidal volume. In ARTSNet protocol, they tolerated a pH of 715. But if you're not comfortable with a pH of 715, you can tolerate a pH of 720, 7.25, something like that. But as long as it is above 7.20, most of these patients will do well with the low tidal volume ventilation. I'm going to also show you the ARTSNet table that you will be using for these patients when they're on the ventilator. So Vikas, can you stop sharing your screens? I'm going to share my screen.
Sure.
So can you see my screen?
Yes.
Okay, great. So this is the ARTSNet table that you'll be using. So you can type it in Google ARTSNet table. This will come up in the images. This is also available on artsnet.org on their website. So on the left side, you see the patient setup, and this is how you calculate the ideal body weight, like in male and female. What you need to do, you need to have their height, right? So for example, for let's calculate for a male of 5.5, 5 feet 5 inches tall. So what you will need, that patient, the initial 50 kg plus 2.3 kg per inches above 5 feet. So this patient will be 50 kg plus 2.3 multiplied by 5, which is 5 inches above 5 feet. That will be like, let's say 13. So this patient's ideal body weight will be somewhere around 63, and you will multiply that 63 to 6. That will give you the starting tidal volume. Okay, and then on the right side, what you see is the PEEP and FiO2 table, and you can see, you know, PEEP of 0.3 going all the way to 1. And there's two ways you can use. You can use lower PEEP, higher FiO2, or you can use higher PEEP, lower FiO2. In patients who have severe ARDS, those patients have very low compliance. Those patients usually require a higher PEEP. And then sometimes they require higher FiO2, sometimes they require a lower FiO2. But in patients who have relatively higher compliance, you know, their lungs are not as bad. Actually, their X-ray looks bad, but their compliance is not as bad. So those patients many times can be managed with a lower PEEP of like around 10, something like that. And then sometimes they require higher FiO2. But you can use this table to basically help change the FiO2 or PEEP and manage that patient. So that will be, you know, that's the basics about managing these patients. And then you see on this table on the right lower side, what you want to do, that it says if PEEP plateau is more than 30, what you can do, you can decrease the tidal volume. If it is, let's say at 6, you can decrease it to like 5 cc per kg. But if it is already, let's say at 4 cc per kg, you don't want to decrease it below 4 cc per kg. If the PEEP plateau is still high, then that patient is very severe ARDS, and there are other things that can be done. Sometimes changing the respiratory rate and sometimes paralyzing those patients. And if their PEEP plateau, but your sweet spot for the PEEP plateau is around 25. So if it is less than 25, especially if it is less than 20, you want to increase the PEEP to bring it close to 20, 25. So that is the table that you wanna
you can stop sharing the screen, and then
okay. So one of the things I want to go back to my presentation. I'm gonna stop sharing the screen, and I was trying to finish at what is the risk of aerosolization with the positive pressure ventilation. So just remember, there's a theoretical risk with the positive pressure ventilation that it will generate aerosols. And in COVID-19 patient, that can be risky, because if it generates aerosol, then people who are especially within the room within 6 feet distance can get infected if they're not using a fully fit N95, or if the patient is not in a negative pressure room. So if someone is on CPAP or someone is on BiPAP and they have COVID-19 pneumonia, you have to be very careful. In most of the institutions here in United States, they do not use positive pressure ventilation in COVID-19 patients, mainly because of the risk of aerosolization. And if someone is needing, let's say, more than 20 liters per minute on high flow nasal cannula, if they are even needing more than 6 or 7, there will be a type of the patient who will have a sudden deterioration, and the most of the institution here just going directly with the mechanical ventilation. But all patients don't need it. And again, it also depends on the resources. If someone is, let's say, on CPAP and you have like full PPE, and that hospital does not carry mechanical ventilation, that patient still should get CPAP or BiPAP, as long as the people who are going to healthcare providers who are going to care for the patients are fully protected. So just keep that in mind. There's a question about the L type and H type on ARDS in COVID-19 patients. I'm going to touch that question because we're already talking about ARDS. So there was this article, and most of the people had read low L type means low compliance, and H type means high compliance. So I would say this is not like just in COVID-19 related ARDS. So ARDS is very heterogeneous. You will see patients with ARDS even from influenza. Some of them have low compliance, some of them have high compliance. And patients who have low compliance, their lungs are very stiff, right? And you will need a much higher PEEP in those patients to open up their lungs. And patients who have a high compliance, so the initial thought process was that those patients have more of blood clots like PE, VTE, microangiopathy. But this is not uncommon in other ARDS as well. That patient will also require a normal ARDS management, but probably will require a lower PEEP. In terms of the mortality rate in ARDS ventilated patient from COVID-19, if you look at different data, you will see from China and Italy, especially from places which were initially very busy, their mortality range from anywhere like 40% to 80%. But if you look at the recent study from Harvard, MGH, and their mechanical ventilated patient, their mortality was 17%. I would say that is probably the same mortality in our institution as well. The problem is that, so why some of the institutions have higher mortality, some of the institutions have lower mortality. It really depends on if they are getting standard ARDS care. Patients, the hospitals and the system which get overwhelmed, they don't get like standard ARDS care. We have seen patients in New York City who are on the ventilator with ARDS on the floor, and many, like during some of the days, they were not even getting seen by physician. These ARDS patients need to be assessed by nurses, like let's say every hour, if not more frequent than that. And they need to be seen by physician multiple times during the day. And COVID-19 ARDS usually requires longer time to heal. We have seen these patients on average being on the ventilator for 2 to 3 weeks before they come off. So and that was the problem with most of the system which got overwhelmed, that their patient go on the vent, they have limited number of the vent, the previous patient is not coming off the vent, and next patient needs vent. And that leads to higher mortality. So the system which have full resources, healthcare providers, full PPE, and they're getting standard ARDS care, all the things which reduce mortality, starting with low tidal volume ventilation, proning, PEEP strategy, fluid restriction, steroids. So those patients, and we're looking for ventilator associated complication, all that thing. For those institutions, the mortality is low. So if the mortality is high in any of the institution, I would probably suspect that institution is overwhelmed and not able to provide standard care for ARDS.
Thank you very much, Farooq. And so we are 1 hour and 15 minutes into this session, and we still have 5 more minutes before we start our interactive session. And why I'm stressing on interactive session, because we have many doctors who are still with us in this studio, and they might have a lot of questions. Farooq, Talha, do you have anything you want to add to your presentation, from your presentations, or should we move to the interactive session?
Yeah, so I think there's a question which I can see in group chat, so I'd like to answer that.
Sure.
That question is from Munir. There are few parts on that. So the one of that is like, should we keep an early intubation protocol or give patients trial of a non-invasive ventilation? So I think I briefly touched that question earlier. So basically, this is a challenging question, to be honest. You don't want to delay intubation where patient acutely decompensates and you end up in a cold situation. So most of the physicians suggest early intubation, but then how you define early is not very clear as well. So this is variable from institute to institute. But I would think if you don't have any contraindications to try non-invasive ventilation, as Farooq described in detail, like if there's no risk of aspiration, vomiting, and then patient is not altered, in altered mental status, you don't really want to use non-invasive ventilation. In those cases, it's reasonable to try non-invasive ventilation in safe environment, since it can increase the risk of aerosolization as well. As long as you can closely monitor patients every 15 to 30 minutes, you can try non-invasive ventilation if there's contraindication, and just follow up, within 30 minutes. Tachypneic and they are, still having hypercapnia or, difficulties, then you can proceed to early intubation. Other thing is, as I said earlier in my slides, if some patients have conditions like COPD, heart failure, or AKI, those patients usually they can sometimes do well on non-invasive ventilation because that supports those conditions. So you can definitely give trial in those cases, as opposed to patients who have no real underlying conditions on those lines. Then you can also actually bypass non-invasive ventilation, especially if they are rapidly desaturating and their oxygenation is worsening really fast. Then you can bypass non-invasive ventilation step and directly intubate them. Other question Munir asked was if we recommend.
Should involve people who are here. We should involve them directly, so that we can ask. Let me ask one question before we move to the interactive session. This question is to both to Farooq and Talha. It's a very basic question. When I was working in New York in ICUs in COVID crisis those days, so suddenly if a patient is ventilated, the oxygen saturation starts dropping. What are the 3-4 major steps which I should look while oxygen is dropping? Like how should I intervene in addition to PEEP and FiO2? What should be my algorithm quickly? Because that's like a rapid response like situation. So I'm not an internist, I'm a general medicine resident, let's say, and I have this situation. What 3-4 steps should I look into to manage that hypoxemia on the vent? Yes, Farooq and Talha.
Yeah, I can start answering that question. So if patient is hypoxemic on the vent, there are many things which can make patient hypoxemic. So I would start thinking about it as a circuit in series, right? So there can be problem with the vent. There can be, which is less likely, there can be problem with the delivery system, starting from tubing, endotracheal tube. There can be problem with the major airways like bronchoconstriction, aspiration of secretions, any obstruction. There can be problem at the alveolar level, like permeedema, pneumonia, pneumothorax, sudden PE, all of that. So I would start with things that can suddenly kill the patient and can suddenly and quickly be fixed. So you want to make sure these patients, many of these patients are on higher PEEP, they are agitated. Sometimes they can self-extubate themselves. Sometimes the ET tube is not, fully secured, and these patients can have like reverse regurgitations, and sometimes they can bite on the ET tube and cause that can cause obstruction. So you want to make sure, and sometimes they can have secretions. So first you want to make sure the patient is the ET tube is connected. So look at the ET tube. Look at the patient. The patient is not biting on the ET tube. Try to learn how to do suctioning from the ET tube. Make sure there is no problem with the suctioning. Okay. So and then listen to the patient. If there's absent breath sounds on one side or not, think about pneumothorax. Then you want to look at the vent. And on the vent, you want to look at starting with peak pressure. Even before you look on the vent, look at the screen which is showing hypoxemia. Let's say if the patient's showing hypoxemia, you want to look at the waveform, how the pulse oximetry looks like. If it is a good waveform, then that is reliable. If the waveform is flat, that means that probably it may not be accurate, and especially if the patient looks comfortable. So you want to look at the screen, which is showing the pulse waveform, and then you want to look at the ventilator. And what you want to see on the ventilator, I would start looking first with the peak pressure. What is the peak pressure? The peak inspiratory pressure. The peak inspiratory pressure, if they're high, let's say more than 40, that's high. If they're less than 30 peak, I'm not talking about plateau pressure, I'm talking about peak inspiratory pressure, because for plateau pressure, you have to do end inspiratory hold, and the patient has to be compliant with the vent, breathing at the same rate as the vent. But peak inspiratory pressure are usually reliable, irrespective if the patient is breathing spontaneously. Now, they can be underestimated in patient, but they cannot be overestimated. So if the peak pressure is, let's say, more than 40, okay, more than 50, more than 50 is too high. So that would suggest that either there is an obstruction in the circuit, patient is biting on the ET tube, there is secretions, or the patient has bronchoconstriction like an asthma or COPD, or the patient has like pneumothorax, something like that. A patient has sudden pleural effusion. So you want to think about that. Some of these patients, when their ET tube, you want to look at the ET tube. When we put the ET tube in, there is protocol that you have to document what is the size of the ET tube and what level the ET tube is, let's say at lip or teeth. And that is usually documented by the nurses or respiratory therapist. And you want to look at the patient ET tube, or let's say at 21 at the teeth, and now it is 16 at the teeth. That probably the ET tube is out, and maybe in the throat. So you want to get a stat chest X-ray, make sure the ET tube is in, and if it is out, that patient may need reintubation. So those are the basics I would keep in mind while evaluating hypoxemic patients. You all are how to manage pulmonary edema. If the patient needs a higher PV, in the end, when you come down, like let's say you come down to the point that you have ruled out these things which are non-ARDS related, and you think about this patient probably has worsening ARDS, then you want to go back to your ARDS-NETs table. You want to make sure the patient is compliant with low tidal volume, patient needs higher PEEP, or patient needs higher FiO2, and you think about those things and adjust those things.
Thank you very much, Farooq. So let me paraphrase what you said, that whenever this thing happens, think of first the fixable problem, the conduction system, the circuit system, rather than the disease itself, and think of like the ET tube placement, secretion blocking the ET tube, obstruction, patient fighting with the vent, dysynchrony with the vent. These are very fixable problem immediately, and if you have no problem with these, then you can also play around the next step, as Aftab and Farooq mentioned, that you can play around with the PEEP and FiO2. Your target is, of course, in ARDS, you play around more with the PEEP. But still you tend to keep the plateau pressure, and the plateau pressure, as Farooq said, that to find a plateau pressure, you have to do a maneuver, and that maneuver is called inspiratory pause. And you cannot do that inspiratory pause if your patient is fighting with the vent. And you should not do very frequently inspiratory pause also, because every inspiratory pause actually increases the hypercapnia. So the plateau pressure is the difference between the, the plateau pressure should be less than 30, and the driving pressure is actually the difference between the plateau pressure and the peak pressure, and it should be less than 15.
Plateau pressure and PEEP, not the peak pressure, PEEP pressure. The pressure, the pressure which is set on the ventilator, PEEP,
peak expiration, okay, yeah. And then you have to keep that difference 15 or less. So these are the numbers you have to play around, and it's like
That's right. Sorry for interruption. Because we were talking about this plateau and peak pressure in ARDS, let me share a scenario really quick for 1
Sure.
minute scenario that you see a patient on the ventilator, you see this pressure and what can you achieve? Then we can go back to the questions, okay?
Sure. Yeah. Let's do a practical application of whatever we learned, and then we'll involve our.
Yeah. Can you see my slide?
Yes, we can.
Okay. So you see here what I shared is that you have an ARDS patient who is ventilated, and the settings on the ventilator that you have the patient on is FiO2 100%. Tidal volume is 650 50 ml, which you calculate as 8 cc per kg ideal body weight. Respiratory rate is 18 and PEEP is 8. Okay. So you look at this and you look at the patient ventilated. The patient is fully sedated, and let's say the patient is drawing tidal volume of 650, which is set, and not breathing above the vent. Let the patient breathing also 18 or 19, and then you do an inspiratory hold or inspiratory pause for, let's say, a second, and you see this patient plateau pressure is 35. You look at the saturation of the patient on the monitor, which is 90%. If you have, let's say, blood gas, which shows a saturation, a PO2 of, let's say, 53%. And then you calculate the driving pressure. You know, here you see the plateau pressure I already calculated is 35, and you have PEEP, which is 8. So 35 minus 8, the driving pressure is 25. So what do you do here? So this patient has many things wrong, right? Starting with, let's say, the tidal volume, which should be set as 6 cc per kg. And because the patient has a higher tidal volume, that's why patient has a higher plateau pressure. Your goal is of a plateau pressure of less than 30 and driving pressure of less than 15, maybe around 13, 12, something somewhere over there. And your saturation, PO2 saturation is like 90%. If you look at the trial from ArtsNet, they usually aim for PO2 of more than 55. This patient's PO2, I said, was like 53. So this patient is not saturating well. So what you want to do, you want to start with the tidal volume, and you want to decrease this patient tidal volume to 6 cc per kg, which is probably, let's say, 400. So you want to drop the tidal volume to 400, 420. And then the next thing you want to look at is the ArtsNet table. If you look at the table, which I may bring back here, this patient is on FiO2 of 100%, okay? And usually these patients with severe ARDS need a higher PEEP, you know, and this patient probably will need a higher PEEP. And you see the patient who has 100%, their PEEP minimal is set as like 22. So you want to increase the PEEP of these patients gradually. You don't want to go from 8 to 22 right away. What I probably will do, I will decrease the tidal volume, and I will increase the respiratory rate in order to deliver the minute ventilation. You know, I probably will increase it to from 18 to 24, and I will increase the PEEP to at least 14. And when you do that, you will see this patient's plateau pressure will probably drop to, let's say, 27, and driving pressure will drop to, when it is 27 and PEEP is 14, 27 minus 14, driving pressure will be 13. So this is, you know, this is what I will do. And then I will monitor this patient with a blood gas and the saturation, see how the patient is doing. And just remember, when the patients are on a higher PEEP, something we forgot to mention, let's say PEEP of 14, 16, those patients will need a daily chest x-ray to make sure their ET tube is not moving up because of the higher PEEP, sometimes because of the higher pressure which is being retained in the lungs at end expiration. That also the pressure sometimes drives the ET tube out. So you want to make sure every day, you know, you get a chest x-ray. Many times there's a limitation. We cannot get a chest x-ray, especially in Pakistan, because of the risk of exposure. If you cannot get a chest x-ray, that's fine. Many of the institutions here not getting chest x-ray in ARDS COVID patient every day, but you want to look at their ET tube, that whatever you mark the first day, the level on the teeth is still about the same. Okay. So I'll stop here, and I'll give it back to Waqas, and we can address more questions.
Thank you very much. That was very practical question. Farooq answered it very well, that whenever you have such situation and your settings are all here and there, so you have to follow a sequence. You do a low tidal volume, as Farooq said, 6 milliliter per kg ideal body, and then it will, of course, compromise the ventilation. So you go up on the respiratory rate to keep a better minute ventilation, and then you play around PEEP. And then your targets are driving pressure less than 15, a plateau pressure, which is obtained after doing a maneuver called inspiratory pause, less than 30, and then all you are doing this to keep oxygen saturation above PaO2 on a blood gas above 60 or a saturation above 90. So this is how you play around, and there might be certain exception cases when you have to sacrifice one of these three factors, but you tend to play around these three factors, and then that's how you manage the ARDS. This is very basics, and as Farooq said, that when you have high PEEP, and we know the COVID ARDS require high PEEP, you have to keep an eye on the ET tube very often, because in I have seen in New York a lot of self-extubations because all these ICU patients were being managed on the floors. Nurses were not very familiar with the sedation protocols. They were not enough sedated to RASS of -4, -5. And as a result of that, ET tubes were being displaced, patients were like agitated, and there were a lot of vent dysynchrony. We did not touch the sedation part in this session. We may do in next session when we are going to talk about the therapeutics in the COVID-19. But it is very important to keep patient very well sedated and keep central sedation. Don't paralyze the patient. They say that number one cause of the GI bleed or stress ulcers in a ventilated patient is actually stress ulcer, which happens when patients are paralyzed but not sedated. Because they are awake, they know that they cannot move, and this causes enormous release of the catecholamines, and that a lot of time we come across the stress ulcers in the ventilated patient. So this is very important to keep them as sedated as possible, but at the same time you have to do these play around these three factors. So here we will stop, and we have a lot of participants. I would request everyone to turn on your video, and then if you have any question, the person who has question can unmute the mic and ask the question very briefly, and then we will take the answer from our panel. And I'm also keeping an eye on our Facebook comments. If you guys are listening us and you don't want to come in our studio, virtual studio, you can still type your question in a comment and we will try to answer. And then I would also persuade our participants here to share their concerns and experiences in ICU. Very briefly, what problems they are facing while managing ventilated patients of COVID. So Munib, you have question, Munib Jan? Because you were asking question in the chat box. Okay, I think you are mute. Anyone can ask question. Yes. Yes, Munib.
So, first of all, thank you very much. It's a very nice presentation. We learned a lot. The problem that we get here is number one, patients on vent, patients with a central supply of oxygen, all of a sudden they start desaturating very quickly. And in spite of intubations, whatever we do, like within hours, they're gone. The procedure that the doctor said, we have tried all of them. We checked the intubation, we checked the ventilation, but nothing works. Another question, it was regarding the anticoagulation protocol. Here in both here in isolation wards as well as the ICUs, we are starting all the patients prophylactically on anticoagulation. So the question I want to ask, what do you think about this? Should we continue this protocol or modify this?
Okay, so you have two questions. One about the certain, in spite of following all the protocols after intubation, you think patient dies and hypoxia is not managed. And the second question is role of AC in COVID. Okay, so Farooq.
Yeah, I can take this question. So the patient who, despite doing all these things, who dies of sudden acute hypoxemic respiratory failure within hours, that patient probably is, we'll have to look at the patient whole data in order to comment, is probably too sick. If the patient has got all the care, that patient, and died within an hour or 2 hours of getting all the care, that patient probably got intubation later. That patient may have needed intubation way earlier in order for the standard therapy to work. Let's say if this patient needed intubation 24 hours earlier and we delayed that and patient was severely hypoxemic, and we're doing it as an emergent measure. You don't want to do it as like emergent measure, because that patient, even a relatively moderate hypoxemic patient, when we intubate the patient, what are the things that change? There are many things that change in that patient, right? One thing that changes is that we start that patient on sedation. When you start that patient on sedation, that can in itself cause hypotension. That is one thing that changes. The other thing that changes is that that patient who was breathing at a rate of, let's say, 35, or in many of these patients, they're breathing at a rate of 50. When we ventilate them, if we put the rate at, let's say, 12, what will happen? That patient will go into sudden acute respiratory failure with hypercarbia. And that in itself, the acidosis will lead to hypotension in addition to sedation. That patient initially was hypoxemic, now the patient will become hypotensive and patient will die. So what you want to do, like initially when you ventilate these, put these patients on mechanical ventilation, if they're breathing at very high rate, they need a higher minute ventilation. You don't think about low tidal volume initially for the first 2 hours. You want to start them at least about the same minute ventilation they were getting before they were intubated. So that's one of the common mistake. And what you want to do once you intubated them, initially you get them like 8 cc per kg for an hour or two, a high respiratory rate around 20, 22, and then you repeat their blood gas in 30 minutes. I bet you if you started them on low tidal volume, especially if you gave them paralytics during intubation, and then you started them on low tidal volume, they were getting a higher minute ventilation. Within 30 minutes, if you get a gas, their pH will be 712, 710, or even less than that because of acute respiratory failure with hypercarbia. So just remember that initially these first 1 or 2 hours until patient gets stabilized, they need a higher minute ventilation. That's one thing. The second thing is when you're starting these patients on sedation, initially what they have is they have a higher sympathetic tone. So they're compensating for, like, they have a high blood pressure. When you sedate them, you take away that sympathetic tone. They have a catecholamine depletion. And now their blood pressure will tank down. So just be ready that this patient will probably need a central line, this patient will need an arterial line to maintain the blood pressure. Just make sure this patient has enough IV access. So those are the basic things I would focus on stabilize, because these patients, putting them on the ventilator is probably the easiest thing to do. But once they get on the ventilator, the trouble comes. Then you probably will need to spend 2 to 3 hours on their bedside after putting them on the ventilator to stabilize those patients. So that's the answer for the first question. The second question was about anticoagulation. Yes, anticoagulation, I think initially there was some doubt that, well, is there really high risk, these patients high risk for VTE? But now I think everyone knows that this, and everyone agrees that these patients are very high risk for VTE. And they usually get VTE even if they're on the prophylactic dose of anticoagulation. Many of these patients usually need therapeutic anticoagulation, or 80% of the therapeutic dose, let's say 1 mg instead of, usually what you do, like you give like 0.5 mg per kg Lovenox if the renal function is normal, for prophylactic to every patient who's in the ICU or bed limited in the hospital. But these patients will require at least twice the dose and sometimes higher than that. And I would probably continue that if there's no bleeding and, as such, obviously, I would probably continue that until their mobility improves. Vakash, you are muted. You're muted.
Okay, yes, Muni, you got your questions answered. Next, anyone else? I think someone was asking about the sedation, but he must be answered by this part also. And anyone else, if you have any question, you can unmute your mic and you can ask your question. If no question, you can ask your concerns which you are facing while dealing with the COVID ICU patients in Pakistan. Meanwhile, I think we answered a couple of questions on the Facebook. We'll wait for 5 more minutes and then we'll summarize our session.
Because there's, I think, a couple of questions we did not answer on this chat forum. And
sure.
If Salah wants to take these questions,
Sure. Prospect of inhaled anticoagulation.
There's a question: is there any contraindication of auscultating chest in COVID-19 ICU patient? Many seniors discourage this.
Sure. Yeah. So I don't know if there's any contraindication, but yeah, there's obviously a concern that it can get contaminated and potentially spread infection. So at least in our hospital, and I think it's the case in most hospitals in US, you have if someone is on precaution, you'll probably have disposable stethoscopes in the room, and we usually use that. And if you have to use your stethoscope, I just use my glove and put it on and listen to that patient. But if that's important, but I don't think so there's any contraindication. Correct me, Farooq, if I'm wrong, but sometimes we have.
Yeah, I agree. There's no contraindication, but obviously there's the risk of exposure. So you want to limit your exposure as much as possible. And if auscultating the patient would not change management, I would not personally auscultate the patient.
Sure. And then we are on team, I'm a fellow here, so we have like multiple physicians looking at the same patient. So we try to limit a number of physicians going in that room. So only one can go and listen. And then if nothing really is worrisome on ventilator and everything looks good, then if you want to skip that exposure, that's fine once in a while. But otherwise, there's no real contraindication as long as you're safely doing that.
Sure. So there's another question: if a patient goes into respiratory alkalosis despite non-invasive CPAP, what's next? So let's say this patient was in respiratory alkalosis because the patient was breathing at a rate of 40, 45, and you're trying CPAP, you're trying maybe even high flow in some situation where it's available for an hour or two, because this patient who's breathing at 40, 45, and their pH is, let's say, 759, 760, 755. That patient has a higher respiratory drive, right? The patient has, because this patient has hypoxemia, this patient is trying to get more air in, and then you're trying to fix the problem, which is hypoxemia or underlying problem that caused hypoxemia. So you gave non-invasive support to this patient. Let's say you started this patient on CPAP, and this patient has respiratory alkalosis. And I probably would not even follow this patient's pH. I would follow how this patient looks clinically when I start CPAP, and how the patient looks clinically in half an hour or 45 minutes after I start the CPAP. So once you start the CPAP, the patient is breathing at a rate of 40 to 45. Half an hour later, this patient is still breathing around 40 or even 35. That probably is not working. The respiratory alkalosis, the CPAP would not be sufficient to treat this patient hypoxemia. As long as you make sure the patient is getting 100% FiO2 from CPAP, that means this patient is heading towards intubation. And this will be the patient I will be very careful after I intubate the patient, because this patient, once the patient gets intubated, the patient is paralyzed if you use the paralytics. Now this patient cannot breathe above. You take away the respiratory drive, the patient cannot start the respiration. And if you set low tidal volume ventilation to begin with, this is the patient who will probably code or become severely hypotensive half an hour, 1 hour, 1.5 hours after being intubated. So this patient will need like monitoring and all other things that I already discussed.
Thank you very much. I think there is a question about the role of CPR. Very important question, because we know that when people are on ventilator, there's a high mortality anyway. Some studies were showing 70 to 80% because there's already cytokine syndrome set in. So what if the patient goes for, like, patient has a cardiac arrest? What are the guidelines? What is the advice to do? How many cycles of CPR, or should we follow the same ACLS protocol? Because we know that there's a great risk of aerosolization and contamination while doing that with minimal benefit. But I would take advice from Farooq and Tala on this. Tala, you first, please.
Yeah, sure. So yes, that's an important question, and I'm pretty sure most of the institutions have their own protocol to address that and some guidelines. We really encourage having talk about code status. Someone who comes in with COVID pneumonia, it's very important to be clear on. But if someone is full code, so we should definitely have that discussion. If someone is on full code, then we in our hospital actually we just we always make sure that we are properly donned. So we have those N95 and everything, face shield, gloves, and everything before we go in. Even if that delays, unfortunately, to go in, it's important. At least in our hospital, we make sure that we have all those precautions before we go in. And as far as duration and those things, there's no specified criteria here. But if someone is already maxed out on FiO2 and high PEEP, and they're hypotensive and requiring a lot of support, and at that point they code. And there's no acute thing which can be fixed, like Farooq was talking initially. If ET tube is displaced or those kind of things, any mucus plugging or any acute thing which you can fix, that's not present there. And it's just because patient's compliance is getting worse and worse, and despite proning and paralytics and everything, at this point they're coding. I would think there's really less hope that they'll come back. So in that scenario, I may do a shorter CPR or shorter code, as opposed to someone who's not maxed out on settings like for oxygen and PEEP, and we still have room to go up on things. Or there are some acute things like ET tube displaced into one of the lungs, or there's a mucus plug as a pneumothorax, or things which you can fix. Then in that case, of course, I'll try my best and try to bring that patient back and try to fix that underlying thing which has caused them to code. But regardless, I would think that it's important to protect yourself first, and we really need to make sure that we have protective equipment before we go and start doing those things.
Thank you very much. Yes, Farooq, your take on this?
Yeah, I agree with Talha. And I would say that if patient has reached to the point of requiring CPR, despite doing everything, that patient probably has extremely poor prognosis. And there are some limitation during CPR on these patients. For example, with the ambu bag, if you use the ambu bag without the expiratory valve that generates aerosols, and there is a risk of aerosol generation and risk of infection in people who are standing next by and doing CPR and involved in the code. So those patients probably, if I would think about what is the chance of this patient coming back, and may do a brief CPR, see if that works. I probably would not do prolonged CPR on this patient who has extremely poor prognosis, and the other people can get infected as well. There's a question on any prospects of inhaled anticoagulation. So I'm not sure which inhaled anticoagulation, Usama, you meant tranexamic acid, which is one of the inhaled anticoagulants that is used in some of the patients who have bleeding from the lungs. And sometimes that can be used in some of the centers. It's off-label use for GI bleeding and trauma. The role for this is, I would say there is no role. There is no proven study that it prevents DVT and VTEs, and it can lead to more problem. But even if it does not cause any side effect, the biggest side effect will be that the patient is not getting standard of care anticoagulation. So give this patient standard of care anticoagulation. Question on role of Flolan or epoprostenol. Flolan or epoprostenol is basically prostaglandin, and the objective is that you want to give it inhaled, right? You give it nebulized form in ARDS patient. There is no mortality benefit with this, but this can improve oxygenation. So let's say if you have done everything, a higher PEEP, a higher FiO2, low tidal volume ventilation, prone positioning, and then low restrictive fluid strategy, steroid, and still this patient is hypoxemic. This patient probably needs something more than that. And that patient, this is usually a last ditch resort before people think about ECMO, which is a big deal, for COVID patients. Many centers who have ECMO are not doing ECMO because of the risk of exposure. But you can use Flolan in that, at a fixed rate of 50 or 100, and then you want to dial it down once oxygenation improves and see if the patient still needs. So it is like just to buy more time until their ARDS improves.
Dr. Hassam has a question. I would request Hassam to turn his, okay, Hassam. So please ask the question and then they will answer.
Okay, so first of all, I would like to share one of my concerns. So we are using here like non-invasive ventilation, high flow nasal cannula and BiPAP at our hospital. But majority of the hospitals have the issue that in ICUs, we don't have the negative pressure systems. So that's a major concern, because if we are using non-invasive ventilation, so the risk of aerosolization is greater. We don't have the negative pressure systems in place. So one of my question was just that for the person who is intubating, is wearing a hazmat or a Tyvek suit necessary, or a surgical gown can suffice provided that he is wearing the respirator or N95 mask, face shield, and everything else.
Very
Okay.
good questions,
And
Hassan.
one more question. Do we have some protocol for preference of high flow nasal cannula over CPAP, or is it it depends on patient to patient? And because we never have used a high flow nasal cannula before. Thank you.
Sure. So, high flow nasal cannula is actually one of probably the best non-invasive mode in patients who have hypoxemia, because it is tolerated pretty well, and it can provide up to 100% FiO2 and very high flow rate. So we usually go with the high flow first instead of CPAP in most of the patients who have acute respiratory failure with hypoxemia. Just because it can provide a little bit pressure as well, 3 to 5. Unless the patient has, let's say, pulmonary edema, those patients will require a higher CPAP, or they have bad atelectasis, they will require a higher PEEP, positive pressure. But otherwise, we usually go with the high flow first. But just remember, even with the high flow, I think the risk is again higher with the CPAP of aerosolization, and probably still less with the high flow. If you're doing high flow with I would start with a higher FiO2, 100%, probably a lower flow rate, probably 20 liters. That will reduce the risk of aerosolization. But if you're going above like 40, 50 liters per minute, then probably you're going into the risk of aerosolization. And that brings me to the first question that you asked: the risk of aerosolization. All these patients who are on a BiPAP, CPAP, who are on a high flow rate, high flow nasal cannula, or who are being intubated. So this, in order to answer that question, we have to understand this disease, how this is spread, right? So this is mainly a droplet transmitted disease. That means it usually is not aerosolized unless the patient is getting intubation or getting aerosolization procedure. In that case, if the aerosols are usually generated and they don't travel on long distances like TB for like many and many meters, but they probably travel at least 6 to 7 feet. And those patients, even if those patients are in negative pressure room, the aerosols are still out there for a couple of feet. So when you're doing those, the intubation and stuff, the recommendation from the CDC and from WHO is that you use N95, but a tightly fitting N95. You know, if you have beard, or N95 is not suitable for your face size, for your face shape, or it's not tightly fitting, then it's not protecting you. And then you use a face shield, a tightly fitting N95 and a face shield, and you use a gown. That is the recommendation. And if you use it correctly, you do donning and doffing. Just remembering that when you did the intubation, you probably have some particles of virus on your gown, on your face shield. And if you're not using the face shield in front of your mask, you probably have some droplets on the outer part of your mask. Remembering that and doing correct donning and doffing, you will be saved just from doing these precautions. But if the patient is not in negative pressure room, then and then you're doing it and you don't have the face shield and you're using the whole surgical the suit, then you know it probably is safer. But again, you will have to keep in mind that the suit will all be contaminated from outside. So you have to deal it as a contaminated suit. You cannot walk out and then see next patient or touch that suit and touch something that you're gonna touch back. So just keep that in mind, because if you're using that suit and you're going out and sitting on your desk, on your chair, that will get contaminated. I probably might use the gown and the face shield and the mask, and make sure that I'm doing correct doffing, because more than donning, doffing is important. Because when you're doffing, let's say you have some viral particle on the gown and you're removing it, it sticks onto your sleeve. And then you touch that sleeve, you touch your nose, you get transmitted from that side. So I probably will use, thing that I will make sure when I coming out of the room, I don't have a virus particle on my body.
Okay, we have I'm sorry, Farooq, I'm interrupting. People who have questions about donning, doffing, and PPE. So Farooq has had a great talk in our previous session that was named From Room Air to Ventilator. It's available on YouTube, on Facebook. You just type room air to ventilator and you can listen that part in great detail.
Yeah, and if you want to learn how to do donning and doffing, go to the CDC website, just write donning and doffing CDC. It will show you all the videos of correct techniques of donning and doffing, and you will have to learn the techniques. You know, I think this is more important than learning mechanical ventilation, honestly, because you have to save yourself. And there is a risk of the people who get frequently exposed, they can have a higher intensity and severity of disease. So just make sure you learn the correct way of donning and doffing. Just go to the CDC website, watch those videos and practice those steps. Just remember those steps while doing it. Do it slowly, take your time, and make sure you do it correctly.
If you are dealing with the COVID patients and like in a ward, all are the COVID patient, then of course you can move from patient to patient because there's no risk of contaminating the other patient. They are already infected. But once you leave the ward and to see your office or to see the non-COVID patient, which I doubt because I heard that people have specific duties. They have specific weeks for COVID ward, which is good actually. This way you can save some PPE because Pakistan has some crisis and CDC has shared 3 strategies on PPE. There's a conventional strategy, there's a conservative strategy, and there's a crisis strategy. So in the 3rd category called crisis strategy, they have mentioned what you can use. And even actually they have mentioned a white coat, a lab coat being used as a PPE cover. But again, the same rule applies. You cannot walk around with a white coat to your office or to the non-COVID patient because it's a mechanical barrier. And as Farooq said, the virus remains alive on a non-living surface, usually 48 to 72 hours. We had also shared about N95 and K95, how to use that. You should not discard them. Once you use for a day, you should put them in a black packet, like a black garbage bag, and leave it in the COVID ward. And then the same mask which you use on Monday, you can use on Friday. Okay, because Tuesday, Wednesday, Thursday, in 3 days, the virus on the surface would die. And then once you use the same mask for Friday, you can use it. And you do this 5 times. So one mask can be used 5 times according to CDC crisis management guideline. And after 5 times, they say that the fitting can be affected or something else. But 5 times this way you can use. So if you need 4 masks, you use this day schedule, you can actually spend 3 months, 2 to 3 months. So we shared all this data with so many medical pages because we came to know that people were discarding. After seeing every patient, you should not discard K95 or N95 because it is reusable 5 times, but it should be 3 days apart so that the virus should have enough time to die. And then you can use it again. So, but again, I'm stressing everyone to see our previous session on the PPE, personal equipment, donning, doffing, everything we talked about. So I have here Talha Said. Talha Said has some question and concern related to ICU care. We all know that we do not have a critical care medicine training in Pakistan. We do not have a fellowship program in Pakistan. What that means, we do not have critical care and pulmonary medicine trained people in Pakistan. And this COVID crisis has actually exposed the need that this is a need of the hour. That I know when we were doing house job, being a medicine PG or medicine house officer, we used to manage a vent, but this could not be a replacement actually, because an internal medicine person dealing with the vent is a different thing versus a critical care attending or trained person, because it's a 3-year fellowship. Pulmonary critical care is a 3-year fellowship. So there's a great need in our country to start and to think about it, that this thing needs training. So Talha, you have any question? If you have still question, you can turn your mic on and video on. Talha Said. I think we lost him. Okay, Farhan Ahmed is with us. Farhan, do you have any comments and questions or anything to share? Farhan is ID fellow at Nebraska Creighton University.
Thank you, Vikas, for allowing me to join. Just related to tocilizumab, yesterday we had a situation again, where there was a back and forth discussion between the ID teams and the critical care teams. We from the ID teams are more lenient toward criteria to administer tocilizumab to the patients, but I think critical care teams are still more cautious when they come up with these sort of medications. So I was just trying to figure out how, what guidelines or Pakistani, physicians or intensivists they are following when it comes to tocilizumab. Are they following the CDC, WHO, or any their local expert opinion? What exactly they're doing?
Yes, Farooq and Tala.
I'm not sure, Farhan, did you mean to ask audience in Pakistan, or did you mean to ask audience in US?
I think both. We will try to figure out how they are doing this thing, and I think it will need your expert opinion on this.
Yeah, here, and obviously I'm not expert on the tocilizumab, but tocilizumab is an anti-IL-5 antibody, and this is a very important question because many people are using it for like every COVID patient. So if you look at the tocilizumab trial, the trial that they used patients with a higher inflammatory markers and a higher IL-6. And just remember, if someone is higher inflammatory markers, they do not necessarily need to have an high IL-6. They may have high ESR, they may have high IL-8, may have high IL-15. So
also.
yeah. So you here what we use it for patients in, number one, it usually for the most part is used as the late inflammatory stage when the viremia has resolved, like after the first 7 days. Although in some cases it can be used early as well, but you definitely want to check their IL-6 level, and if their IL-6 level is very high, those are the patients who may benefit, but there's no data if they're going to get any benefit in additional to steroids, because if you use steroids, it will not only suppress inflammation related to IL-6, it will suppress inflammation related to any interleukin, any inflammatory marker. Okay, so tocilizumab here in United States, at least at my institution, is being used on very limited patients, in patients who still have high IL-6 despite getting steroids and standard of care at late stage of the disease after the viremia, which is first 7 to 10 days. And I think in Pakistan, it is being taken as a magical, for the most part, what I have seen, and obviously people who are working in Pakistan will be able to shed more light on it. It is being used, are considered by many people as a magical go-to drug, which it is not.
Actually, the studies which came from to support the tocilizumab were very small sample. They were from China. One study was 15 patients. One study was 21 patients. So 21N and 15N. That is very small, and they were all retrospective studies. So that is why the evidence is not very great. But again, as I said, this is like a rescue thing when you don't have anything else and you have some data to support, you just take a chance. The downside is that it is very expensive. And even in spite of this injection, some people may die. And when they die, the families, they always remember the last thing, which is the expensive injection, and they think of it as a poisonous injection. We have spoken a lot in our public awareness session for non-doctor layman people about what is tocilizumab, what is the data, and why people think that it is poisonous injection, when it is not actually. But the data is not very supportive. 21 patients, 15 patients, and they are all from retrospective. We have a question here about the thick secretions in these ventilated patients, because that's a very practical question that what should we do, medicine people, general people taking care of ventilated patient, what should they do to make them like thinner or not to plug the circuit?
Okay, so before we answer this question, we'll take this as a last question because I think some of our speakers will have to go. And Talha, if you want to answer this question, I can defer it to you.
Sure. Yeah. So yes, secretions can be a problem, but with my personal experience, a lot of those patients actually have dry cough and not a whole lot of secretion, but and in our institution, they are running a trial where they're using, like, I think Dornase alpha, which thims your secretions, and then sometimes they use mucomist as well, but those are not proven, and we're just using them as part of research trials here. Other than that, I would just think good respiratory therapist care, good frequent sectioning. There's sometimes closed system with suction ports attached to ET tube, which can be used. But other than that, I don't really see, other than good frequent sectioning or maybe chest compressions to help those secretions to come out. If there is any magic thing which you can do, I mean, we can do things to dry out secretion, but really we do that as a part of palliative care. We don't really recommend that. That makes it more difficult to bring those secretions out actually.
Yeah, I agree. I would make sure this patient does not have a ventilator-associated pneumonia. So just do cultures of the thick secretions, and then regular nebulization, saline nabs, albuterol nabs can help. But I probably would, and frequent suctioning is the key. I probably would not use nebulizer in non-ventilated patients because that will increase your risk of aerosolization. But in ventilated patients, it can be used. But again, I think these patients have been intubated for weeks, for days. You want to make sure this patient does not have tracheitis or ventilator-associated pneumonia. Look at the chest X-ray, see if there's any new consolidation. Then start the patient on antibiotic, do cultures of the secretions.
Thank you very much. And this concludes our session for today. We are 5 minutes over our time, but I'm grateful to Farooq Abbas, who took time and came, and he actually led this talk. He assigned all the topics and helped our other colleagues to coordinate. I'm thankful to Tala Nawaz, who took time and then came here, and I'm very thankful to Aftab Ahmed, who was actually working today, but he managed to take some time off. So this is a talk. Basically, this talk will be available on YouTube, on the Facebook links. It will be available on as an edited version as well as a raw version. This was just to help our colleagues in Pakistan to understand the basics of ventilator and what they can do. I know we cannot cover everything in 2 hours. It's a 2-year fellowship, 2 to 3 year fellowship. It is not easy to manage in 2 hours, but these are the highlights. Like if everything is available on YouTube, videos, literature, we are always available. If you have any question about your COVID care in ICUs, our colleagues are all available. We are working to make a format to do EICU. Me and Farooq and a few others we are working on this, and soon we will be sharing our WhatsApp numbers and in a way that one fellow in America should cover one hospital in Pakistan. Like one should be dedicated to Mayo Hospital, one for Allied Hospital. It's not like you guys don't know. You guys know better than us. It's just to share our experiences, because there's more advanced critical care in America there, and still America has the most number of COVID cases in the world. So we just want to share our own experiences, our mistakes, our learning points with you guys, so that you should make use of them if you can save any single life. I know it's a crisis situation for Pakistan, who does not have a critical care specialty. This is a need of the hour. We do not have control on these things, but what we can do, we are trying to do, and we will keep on doing that. We have done a lot of awareness sessions in Urdu language for public awareness. This is our 3rd doctor's awareness session in English language. And we are going to do one more session about the therapeutics, but we have covered a therapeutics part in our previous session from room air to ventilator. But we will be talking more about therapeutics. Someone asked a question about lopinavir, ritonavir, and interferon. There is no evidence. The lopinavir and ritonavir combination did not prove to be any of benefit. So there is no evidence for this combination. The triple thing is still under testing in Japan, and it is still, we are waiting on a lot of results. So all these trials we are waiting, but do what you can do a lot of proning. You have to figure out a way to do at least 12 to 15 hours of proning in the ventilated patient. Even in the non-ventilated patient, like a moderate pneumonia patient, proning has shown benefit. It improves the circulation to the posterior parts of the lungs and the preferential oxygenation, thus decreasing the physiological shunting. And this is something you can do without spending a lot of money, just like some manpower. But make sure you do not displace the ET tubes, and play around those numbers which Farooq, Tala, and Aftab talked about, all those 3 numbers, and you have to target your driving pressures, your petrol pressures, and your PEEP according to those numbers. And then make sure that you put all this patient on good GI prophylaxis. because there's a great chance of stress ulcers in these patients when they're intubated for more than 2 days. Do not do unnecessary CPR. I know I have talked to my colleagues in Pakistan. They told that families have created a lot of trouble when you guys don't do CPR. They think you're gonna kill the patient deliberately. But again, they are laymen. They should not be the people driving your guidelines. So do first make sure that you ensure your own safety, because there is very less benefit of these CPR, because already a cytokine syndrome is set in. Even they are revived, they go back to the cardiac arrest again. So these are the highlights of today's session. And with this, I'm concluding, and we'll come back in 2 to 3 weeks with one more session on therapeutics. Share these links with all your doctors, healthcare professionals, all the pages, and we are just trying to help our country. And this was a project of King Edward USMLE Forum, and all the presenters, they are the admins of King Edward USMLE Forum. Thank you very much. Take care.
Thank you.